Welcome to The Exchange, a series of rounds to drive change. This webinar is brought to you by Interior Health in partnership with the Canadian Medical Association. I am Dr. Harsh Handel, Executive Medical Director for Physician Engagement, and I would like to acknowledge that we are meeting on the traditional and unceded territories of the First Nations. These are the territories upon which we live, work, learn, and collaborate together. We would also like to recognize the Métis Nation BC, in particular contributions of the Métis people to the diverse Aboriginal landscape of the interior. I myself am a settler on the lands of the Syilx peoples here in Kelowna. I would like to welcome today's session is to Dr. Eiko Ueda. Dr. Ueda is a pediatrician in Vernon, and it's fantastic to have Eiko here, and with her partner, Carol Harper. And Carol and Eiko have done considerable work in the area of Dyad Partnerships and why they work. So I'll turn this over to Eiko and Carol. And thank you too for being here tonight.
Great. Thank you so much, Harsh, for that introduction. So welcome to the Exchange, and thank you all for joining us. Carol and I are really excited to share our learnings and experience about Dyad Partnerships and why they work. And Carol and I join you from the traditional, ancestral, unceded territory of the Syilx First Nations. So over the next 30 minutes, we would like to explore with you three specific objectives around the Dyad model of governance. Firstly, how it might look in healthcare. Secondly, why it is valuable. And finally, 5 distinct characteristics that have been recognized as being key features of a strong dyad partnership. What is a dyad? So Sanford and Moore, they've done a lot of research in this field of dyadic relationships. They define dyads as many teams of 2 and sometimes 3 people who work together as co-leaders of a certain system, a division, a clinical service line, or project.
The ideal partnership defined by physician quality improvement in interior health is 2 healthcare professionals, a physician matched with a non-physician administrative or operational leader, who are committed to the partnership, share a passion, and incorporate the quadruple aim vision. We've incorporated the quadruple aim from the Institute of Healthcare Improvement into our definition. It is like a 4-legged stool. It has 4 parts: improving provider and patient experience, improving population health, at a cost we can afford. You'll hear throughout this presentation some of our dyad stories, beginning with Dr. Eiko Ueda.
So as you can see, this is a photo of my PQI cohort 2 group. So you might be wondering, how does a pediatrician who has worked in interior health for 27 years become so passionate about dyadic partnerships? Well, I'd like to share with you my personal story. 5 years ago, I was burnt out. I was even contemplating an exit from medicine. I felt a huge sense of responsibility to my patients. I felt like I was on a treadmill and I couldn't get off. I had little control over my work. I was exhausted and felt powerless. Perhaps you too are familiar with these feelings. I was then fortunately introduced to the science of quality improvement and decided to join the PQI program. You can see me in the front row on the very right-hand side. I was paired with an open-minded operational partner, Yvonne Taylor. And you can see Yvonne on the left in the second row. She's the Director of Primary Care, North Okanagan Clinical Operations. I later discovered that pairing of physician with an operational dyad partner is unique to the PQI Interior Health Program and not done intentionally in any other PQI Health Authority program in the province. Yvonne and I had a shared vision to improve the delivery of care to the patients and families in the pediatric diabetes clinic at Vernon Jubilee Hospital. We started our relationship by organizing a journey mapping session with our PQI consultants. Yvonne provided the operational support for the entire diabetes team to participate in this all-day event. There were about 20 people who participated, including physicians, nurses, dietitians, administrative staff, and perhaps most importantly, our patient partners. Yvonne requested that the executive director give some opening remarks, and Roger Parsonage kicked off the day with some really inspiring words. The day was spent identifying opportunities for improvement, and to be honest, it was a bit overwhelming as there were so many of those identified. But we also brainstormed possible solutions and prioritized them. It was a really energizing day. Working and learning with Yvonne gave me insight into the challenges faced by operational leaders, but also an appreciation for her skill set, which was very different than mine. She was able to remove barriers that I had not been able to do alone in the preceding 3 years. For example, she was able to optimize the operational structure in the clinic by creating a coordinator position. She firmly embraced and emphasized the importance of the quality improvement work and its central importance to patient-centered care. Her messaging and mine were consistent. And by working with me, I believe that she gained a greater understanding of some of the clinical considerations when making certain types of decisions. My experience with Yvonne has profoundly changed the way I now view my operational colleagues. It's not us and them, but we. It has absolutely activated my agency. So in other words, it's giving me power, the ability to act with purpose, as well as courage, that emotional resource that you need to choose to act in the face of adversity or uncertainty. This experience brought back to the fore all the reasons why I went into medicine in the first place. It's opened up a myriad of connections and relationships for me, and I feel that I am part of this organization, that I have something to offer, and that I matter. Dyadic partnerships, though, can look different than the one that I've described, and Carol will be sharing some of these with you on the next slide.
Echo, your story is so fantastic, and I love what you said about feeling connected and having something to offer. Isn't it true that we all want to feel like we matter? Carrying on with unpacking the picture of what does that dyad configuration actually look like? The following dyads listed on this slide include 20 physician and administrative partners. This list reflects diversity and matching partnerships in PQI cohorts, as well as the reach into the organization. You'll see on the left-hand side are the physicians and the right, the administrative partners. On the right side, dyad partners are from multiple levels and a variety of areas in the organization, including directors, program operational management leads in access and flow, IMIT, business continuity, mental health, substance use, primary care, respiratory therapy, end of life, and physicians also are even more diverse, perhaps, in their areas of expertise and coming from a variety of specialists and GP areas. The approach of the pairing, of the dyad pairing, is not cookie cutter. One size does not fit all. And the dyad partnership was a new concept when this started 4 years ago in interior health. And some convincing of the idea was necessary. We started asking physicians, would they possibly consider working in a dyad partnership? Fast forward, 4 years later, physicians registering for the cohort now, the training ask, who is my dyad partner? So our conversation has changed. Now we ask, who might you choose to work with? Who do you know that would be enthusiastic about your project idea or problem to solve, or rocking our shoe, like we say? One example of the impact of the reach in the organization may be helpful. This dyad partnership between a hospitalist and a nurse working in access and efficiency, the project was to develop electronic progress notes for hospitalists. In short, the problem was deciphering illegible handwriting. Physician notes recognized that it was not working. At the first meeting, the operational partner nursing the nurse working in access and efficiency reported back to the physician partner what the allied health team had said. And here's their quote. I didn't think that the physicians would listen to us and that they would change this part of the template based on our feedback. They really heard our voice. So the project transitioned very quickly from a physician-focused only project to more of a collaborative, this is our project together. I'm going to pass over the mic to Eiko for the next slide, who will walk us through the difference between physician and administrative leadership cultures.
So this is a rendering of the traditional model involving physician and administrative leadership, very much siloed work. The work is done side by side with each expert working essentially in their own swim lane. So on the next slide, we see here that the reason behind this siloed governance heralds back to very fundamental differences in the mental model and training of physicians and administrators. This table is summarized from work by Sanford and Moore, and although it provides generalizations, I think it sufficiently highlights the fact that there are indeed differences between how physicians and administrators approach healthcare. So on the left-hand side, physicians value autonomy. In the hierarchy of clinical medicine, the physician has traditionally been the person to make final decisions. Physicians tend to advocate for their own patients. They want financial decisions made that will improve the function in their area of interest. And they want things to happen quickly. They feel loyalty to the profession and the Hippocratic Oath. And they don't necessarily view other physicians' opinions as representative of their own. I think we've all attended department meetings where strong dissenting opinions have been raised. Administrators, on the other hand, value interdependence and follow a designated reporting structure. They advocate for the hospital as a whole or patients as groups. They focus on the finance of the entire organization. Administrators recognize that timely response is dictated by the capacity of the system. Their loyalty is to the organization, and they sometimes believe that a physician lead can speak for the entire medical group. Again, these are generalizations, and there are exceptions to each and every one of these points. So let's now move and talk about an alternate way of governance. Over to you, Carol. Next slide.
Thanks, Eiko. So Eiko has described, you'll see on the left-hand side, the silo approach. And shifting to the right of this visual, this depicts the dyad collaborative model. This model aims to shift the traditional healthcare delivery, the physician and operational independent approach, towards integrating a system focused on quality, collaboration, and team. In other words, there's a shift in the governance structure from that of a parallel approach to one where the culture is collaborative. Notice in the middle, then overlapping parts in the center, the scope of influence. This allows for that collaborative discovery, the scope of influence about the project or PQI project and the process that they're working on. And also each dyad partner has their own unique sphere of influence about the work. And you'll see the arrows going out. So as the success of the project expands outwardly in the organization or the province or spread at a national or international level, everybody is informed and part of that as it grows. So some of the projects don't go to international level, but certainly some do. So it's an interesting model. And this is a work in progress. This is a draft of a model that we anticipate will likely change given the feedback with dyads. But I think it's a pretty good start. And over to you, Eiko.
So you might be wondering, why are dyads valuable? They are valuable because it benefits patient care. And how does Dyad Partnership benefit patient care? It does so because Dyad Partnerships increase efficiency. Each partner in the dyad is able to bring his or her unique skill set to the partnership, and they are able to leverage each other's strengths. The goal is for each partner to be able to work at the top of their ability. Secondly, there's less burnout and loneliness because there is shared responsibility. Thirdly, by working together as a team, trust is built. Having regular meetings improves communication, and effective communication in turn increases the pool of knowledge through greater transparency. And finally, dyads are valuable because working together builds physician engagement by embedding physicians into the operational structure of the organization and providing mentorship and leadership skills. All right. So how do you develop highly effective dyad partnerships that benefit patient care? Carol had mentioned earlier that there is no one-size-fits-all approach to pairing. However, these 5 characteristics have been outlined by Cortez and Schmold as being critical to the development of a successful dyad partnership. Over the course of the next several slides, we'll explore these 5 characteristics in more detail as we share the results of the Physician Quality Improvement IH Alumni Survey. Over to you, Carol. Next slide.
Great. What you see in front of you is our preamble for the survey, and I guess why we show it. It describes really why we did the survey. And the overarching purpose for the survey was to learn about the dyad experience. What has worked well? What could be improved? The aim was to engage PQI alumni in learning. In other words, a quality improvement principle, all teach, all learn. And also to engage those who are involved in the process of co-creation in the dyadic partnership. Additionally, we wanted to celebrate successes and identify opportunities for strategic steps forward. Our engagement commitment was to keep alumni informed of the results and the progress. So in the spring of 2021, we invited 61 PQI Dyad alumni from the first 3 cohorts to complete the online anonymous survey, which consisted of both Likert scale and open-ended questions. Excluded from the survey were those alumni who either chose not to have an administrative dyad partner, or for those for whom the dyad option was not fully developed as mentioned in the first cohort year. We had a 55% response rate, of which 65% were physicians and 35% were operational partners. The majority of respondents were from cohort 3 at 70%, and the remaining were from cohort 2 at 30%. And next slide. We asked our dyad alumni, what was the most important part of your experience? You can see by this graph, the top 5 highest responses included trust at 94%, using quality improvement methodology, 88%, communication, physician engagement, and improved the quality of local projects, all at 85%. Interestingly, these responses generally reflect all 5 characteristics common to successful dyad. And Eiko will continue the 5 characteristics in the next slide, sorry.
Thanks, Carol. So this is the first of the 5 characteristics, and that is common core values. There are several high-performing organizations, including the Mayo Clinic, that identifies the value of patient-centered care as being at the core of everything they do. There is this explicit shift from a volume to a value-based system. Establishing core values was important to 84% of our PQI alumni respondents, and 78% reported valuing a shared common vision with their partner. In the qualitative portion of the survey, one alumnus wrote about the joy in sharing a common value of creating positive change for patient care, while another expressed gratitude to be able to work side by side with a physician champion to improve quality of care. Next slide.
The second characteristic is collaborative working relationships. Working together involves learning together. Peter Zengi, a systems scientist in organizational development, describes a learning environment as one in which people begin to participate in this pool of common meaning that is capable of consistent or constant development and change. He highlights the importance of gleaning collective intelligence and developing a shared vision by engaging in dialogue and also challenging defensive routines. Our alumni wrote in the qualitative section of the survey, establishing a team around a common goal which replaces the traditional siloed approach, which arranges teams according to their designation and training, which obstructs team-based care, which is almost always interdepartmental. In short, someone wiser than I said, these dyads are making Swiss cheese out of long-standing cultural differences between physicians and administrators. And that's reflected in the survey results. Almost half of the respondents identified their mutual relationship as a most important component of their dyad experience. Details of the partnership included sharing perspectives, discussing challenges, adding a different lens, and shared experiences. And the third, next slide, the third is transparent communication, third characteristic. Open communication requires trust, curiosity, and desire to maximize learning about the system. Dyad leaders who communicate well with each other also generally communicate well to those they serve and provide consistent messaging. Our alumni wrote about the ability to build bridging between management and physicians. You heard some stories on that. And engage in dialogue, bridging gaps in communication with other healthcare providers and learning about barriers involved in doing so. In our research, we found that in an organizational culture where there's trust and collaboration between physician and administrative leaders, for example, the Dyad model, there's also greater transparent communication, data and information sharing, and the creation of a shared vision. Our cohort Dyad alumni reported 88% strongly agree that communication between Dyad partners was timely and intentional. And it's over to you, Eiko, for number 4 characteristic.
So the fourth one is mutual respect. This is recognition that each partner is a specialist in his or her field, and that each is equally important in achieving success. So mutual respect is a key driver of the successful Dyad partnership, because it promotes this culture of learning and an acknowledgement of the valuable and different competencies of each partner. In the survey, some of the physicians wrote that they appreciated being able to get a firsthand glimpse of, quote, the other side, and that they gained insight into the administrative aspect of medicine, something that is traditionally not part of medical school training. Others expressed joy in getting support from an operational leader to complete the project, while others felt that it was eye-opening to hear another perspective. The quote that stands out for me the most, though, is from a physician who wrote this. He wrote, "Can't do this work without a dyad partner. It's just that simple." I think that really sums it up. Next slide. And finally, the fifth key characteristic is complementary competencies. So a well-paired dyad accepts mutual necessity and constructs shared responsibilities in order to innovate solutions that are really patient-centered. Healthcare now is too dynamic, too complex for any one organizational leader to be good at everything. So if physicians and non-physicians can learn and work together, it should improve integration, physician engagement, teamwork, and innovation. It's about building strong relationships that withstand challenges and that dare to risk together. So in summary, we hope that this presentation has provided you with some understanding of what a healthcare dyad partnership model entails, the power of this model in healthcare delivery, and the 5 key characteristics that are core features of a well-paired, intentional partnering between physician and administrative individuals. My experience in dyad partnership has brought me so much joy in work, and I hope that you will also consider this if you have not yet had an opportunity to do so. These are absolutely unprecedented times in healthcare, and working together and building strong relationships can be an antidote to the stress, loneliness, and high work volumes that we are all facing. So this concludes the formal part of our presentation, and Carol and I thank you for your interest in this topic. And I will now hand the ball back to Harsh, and we would be happy to answer any questions.
Thank you, Eiko and Carol. Much appreciate your presentation. So how do you initiate a dyad? So what is that, Eiko, for you? What was the first conversation?
You know, Harsh, I think it just really comes back to relationships, like recognizing that Yvonne was not this theoretical person working in an office off-site from me. It was recognizing that she was a human being. And as funny as it sounds, realizing that she and I were on the same side and that our goals were in fact exactly the same and that we wanted the best for our patients. And I think it was just that breakthrough in realizing that she was just like me in healthcare for the exact same reason.
I think we have more in common than we think. And probably part of it, what you are pointing out, there's stereotypes in physician culture, as well as in administrator culture, and assumptions of how the other thinks without getting to know the other. So
yes, and I think, Harsh, I think it's important to recognize that these relationships take time. You know, it's about being able to trust that other person. So it's not something that happens immediately, and so it's something that can't be rushed.
Mm-hmm. So Carol and Eiko, what do you think are some of the barriers to further extend this model of leadership in interior health?
I can start off, Eiko, if that's okay.
Absolutely, Carol.
That one of the main barriers is time for the administrative partner, and that it came up again and again in discussions, in further conversations with dyads, and also from the survey, and so I think that's one of the barriers going forward. And I think some of the other barriers are just that it's a new model for PQI and interior health. I don't think it's a new model overall, but for interior health PQI, it's new, and there's some access, there's some flow issues, and just logistical things that I think could be improved to make it really sing, and some dedicated time, I think, to the forming, some structure around it. And Aiko, do you have any thoughts in addition to that?
I think capacity, I would reiterate, Carol, that it's the capacity that's, I think, the major barrier at this time is, I think our operational partners have so much on their plate. Their portfolios are large. And, I think it's that. And then, one of the valuable things about the Dyad partnership is that because it's embedded at the very start of every PQI project, the likelihood that the project will align with the strategic plan of the organization is also higher. So I think that as things become more meshed together, I'm hoping that this whole time component will be less of an issue. But having said that, healthcare is so complex right now that everyone is really working at the top of their capacity. So
I'm going to put it to you: how do you communicate the effectiveness, the benefits of dyads to the rest of the organization outside of PQI, as well as British Columbia?
I think I can. Oh, you
Carol,
start.
why don't you go ahead? No, you go ahead, Carol.
We're so polite to each other. It's awesome. So what I was thinking about Harsh is, we've Aiko and I have really been a Dyad partner in writing a white paper, and with obviously other authors on this paper, and I think messaging that out and really gathering a group of people, a very small, maybe working group. I know it sounds kind of standard, but let's figure out how to message this out. So at multiple ways, there can't be just one. There's no one way to do it, but at multiple ways, and perhaps publishing a paper, and obviously thank you very much for this opportunity to speak at the exchange. And I think that's one way of getting the word out. So I think that we can tick that one off thanks to you, Harsh. Aiko?
Yeah, I think that physicians who have gone through PQI training, they have been involved in a variety of different projects throughout the organization. And there have been some projects that really have shown excellent return on investment for the operational partner and ultimately the organization, whether it's combating alcohol use, whether it's streamlining how results are processed and looked after in the emergency department, how quickly people who have myocardial infarctions are managed in the periphery before arrival to the hospital. These have all been shown to be beneficial not only to patients themselves, but also to the organization in terms of lessening healthcare costs. So, I don't see this as just being something that is available to just people in leadership. I think that this is available at multiple levels. I think that any physician can get involved in this sort of activity and seek out a manager, seek out an RT. If you identify a problem, find someone who shares that passion with you and speak to your operational partners about it, and if necessary, approach some PQI people. But I used to think, oh, I'm just this small person in this big cog of an organization. What can I do? I felt really disempowered. And this has really made me believe that even me, this general pediatrician in Vernon, I can actually do something. I have a great idea. I'm there on the front line and I can make a difference. And I with the help of many people in the organization, I can now navigate my way through and figure out who can help me in identifying and sifting through the problem that I'm facing. So, you know, I noticed, you know, that one comment, Glenn, about, you know, maybe it's just available to people in leadership, but I would challenge you on that. I think it's available to everyone. I think every physician who identifies a problem has, you know, can get agency to make a difference.
And
And I think, go on,
sorry.
Carol.
One more little thing about getting the word out. There have been several presentations at the BC Patient Safety Quality Forum and also at the IHI International Forums. And that's one way. And also we're having interior health seems to have this ability and the support from executive and the right teams and the physicians that our projects are spreading far faster and very at a quicker pace than other areas in the province in the same PQI program. So I think we're onto something with this, Dyad.
And I think that as you've put it there, Carol, this is the only program that has that unique dyad structure. So one can compare against the other 4 programs out there as to what's come out of it. What's the return on the investment on this? And I want to get back to Aiko. You and I had a conversation a while ago about going for a coffee. The power of simply going for a coffee with an individual and getting to know them, because dyads are fundamentally relationship-based, right?
Absolutely. Absolutely. I think that, you know, communication and getting to know your partner is really key. Understanding how does he or she, what are their values? What matters to them? Who are they as human beings? What are their stresses in life? I know a lot about Yvonne and likewise she about me. Even though she and I are now finished our project, I can text her at any time and she texts me right back. That is a relationship and I value that relationship. And I feel we're on the same side of the fence, which is really wonderful. And it adds a huge amount of joy in my day-to-day work, knowing that, you know, these are all my people. It's really great.
That's fantastic. Some of the questions here have to do with compensation models. How can we find the balance to ensure that we create that space for partnership? And the other the question is, how do we encourage and welcome dyads in front of the senior executive team, board meetings, and all the various committees in terms of presenting, but being involved in those discussions? So there are still challenges ahead. There are still, you know, this is early days. If people can remember back in interior health about 3.5 years ago, there's people weren't talking about dyads back then. But now the question is, who's my dyad partner, as you said?
Mm-hmm. Mm-hmm. Yeah, no, I think it is early days, and it's really exciting that more and more people are looking at working with an operational partner as an expectation. You know, they expect to do this work together, and it makes the work fun. You know, in terms of the question about the compensation, you know, physicians that are involved in quality improvement do get sessional pay for the work that they do. You know, I think that some of the work that Carol and I are doing in the background on this area, it's about creating a framework, not only within the PQI program, but also looking at that very issue. is, how do both sides, as one of our alumni respondents to the survey said, how do both sides get compensated for the time and effort and emotional commitment they put to this? So I agree with you about that comment. I think that but it is a work in progress, but it has been recognized. It was highlighted in the survey, and there are some thoughts around that. So stay tuned.
So with that, I'd like to thank the both of you for taking time out, doing this presentation. For the people in Interior Health, the people who connected today. There's our link to the CMA Wellness Hub. The other code will get you to the new IH website. And since we always bring a quality improvement lens to our work, there's opportunity to check out our new public website. There's a medical staff tab. And to be able to provide feedback on how can we improve this website? How can we connect better to you and to the individuals and communities within Interior Health? So with that, I'd like to thank both of you again and acknowledge the support of the Canadian Medical Association and Interior Health and putting together these presentations. It will be posted to the IH YouTube channel, as well as a podcast of myself having a conversation with Eiko and Carol regarding why are they in this? What are they doing? And again, what is the positive change that has occurred in their lives? So with that, thank you very much for taking time out of your busy lives. Stay safe, stay well, and take care of one another. Good night.